It's based on perspicacious review by Dr. Reza Lankarani, general surgeon founder, Surgical Pioneering newsletter and podcast series, editorial board member, Genesis Journal of Surgery and Medicine. So, listening to tech commentators who have never actually held a scalpel predict the future of surgery, it feels exactly like listening to a backseat driver explaining how to win the Indy 500.
Oh, absolutely. It's a lot of noise.
Right. It makes you ask who you should actually trust when it comes to the real future of AI and robotics in the operating room. So today we are doing a deep dive into the work of Dr. Sanjeev Kumar, who is a leading gynecologic oncologist and robotic pelvic surgeon. Our mission here is to really separate that sci-fi hype from the gritty, high-stakes reality of modern medicine.
Yeah, because, the public conversation around AI right now is just deafening. But it's largely driven by voices completely removed from patient care.
Exactly. People who aren't in the room.
Right. If we want to understand the actual limits of artificial intelligence, we have to look at genuine surgical mastery. And Dr. Kumar really provides that baseline. I mean, he adopted robotic surgery back in 2006.
Wow. That's incredibly early for that field.
Very early. And by 2017, he was actually the 8th busiest robotic pelvic surgeon in the entire U.S., operating out of the Baptist Cancer Center.
Okay, let's unpack this for a second, though. If robotics give us that kind of reliable, perfect, precision-like, entirely eliminating human hand variation, why can't AI just completely take over the surgery?
Well, I mean, that assumes cancer surgery is a predictable engineering problem.
And I'm guessing it's not.
No, it absolutely is not. Disease severely distorts human anatomy. A tumor doesn't grow the way it looks in a textbook diagram,
Yeah.
It might aggressively wrap around a major artery,
Oh, wow.
or it pushes a vital organ completely out of its normal position. Every single operation is a totally unique biological environment.
So a robot can make a perfectly precise cut, but it doesn't know why it's cutting there.
Exactly. It completely lacks the contextual intuition to realize why a nerve is suddenly a millimeter to the left. The machine is just the instrument. The surgeon is the intellect.
It's like having a state-of-the-art spaceship, but you still need a veteran pilot when you're navigating a completely uncharted asteroid field.
That's a great analogy. The robotics don't replace the surgeon, they just bypass human physical limitations.
Right, the physical limitations.
Yeah, and because of that, Dr. Kumar used these robotic systems to operate on morbidly obese women, patients exceeding 400 pounds. Traditionally, other doctors routinely rejected these patients.
Wait, really? Just flat out rejected them?
Yeah, because the sheer weight and thickness of the abdominal wall makes visibility and physical access almost impossible for traditional open surgery. It leads to extreme risks of blood loss and severe infection.
That's terrifying. But the robot changes that.
It does, because the robotic arms pivot from a tiny entry point. Dr. Kumar could navigate deep into the pelvis without a massive incision.
So the technology creates the opportunity, but it's the clinical courage of the human that actually saves the patient.
Absolutely. And that courage also changes what kind of care is available locally.
Right, because instead of patients traveling from Memphis all the way to Chicago or Dallas just to safely start a family, Dr. Kumar pioneered outpatient robotic cervical circlage right there in his community.
Which is just a massive leap forward. A cervical circlage involves placing a really complex stitch around the cervix to keep it closed during pregnancy.
To prevent premature birth.
Exactly. Doing it robotically allows for extreme precision in a highly sensitive area, turning an invasive, grueling ordeal into a simple outpatient procedure. He also introduced APEC to the Memphis region.
Right, that's the warm chemotherapy wash, isn't it?
Yeah, so immediately after removing a cancer, the abdominal cavity is literally washed with a heated chemotherapy solution.
I understand washing the area to kill the remaining cancer cells, but why does the chemo have to be heated?
Well, heat actually dilates the tissues. Raising the temperature allows the chemotherapy drugs to penetrate much deeper into the abdominal lining.
Oh, so it gets the cells you can't even see?
Right. It actively destroys microscopic cancer cells that the human eye and even the advanced robotic camera just can't detect.
It really reframes the whole conversation you constantly hear around longevity. Right now, longevity is marketed to you as this trendy wellness optimization.
Yeah, like taking the right supplements or sitting in an ice bath.
Exactly. But real longevity is this. It's treating complex obesity and aggressive women's cancers. It's genuine clinical intervention that extends the actual quality of life when someone is facing an immediate life or death threat.
That really is the intersection of technology and patient care. The tools are evolving, but the goal remains keeping vulnerable people alive when their bodies are turning against them.
The technology is undeniably going to keep advancing. But here's a provocative thought for you to mull over as we wrap up. As AI inevitably gets smarter in the operating room and starts automating more of the routine steps, how will the next generation of surgeons actually learn that irreplaceable human intuition? When a machine's algorithm confidently tells a young surgeon to cut, how do they develop the gut feeling required to say no?
It was based on profound review by Dr. Reza Lankarani, editorial board member, Genesis Journal of Surgery and Medicine. To access additional details, please refer to the Surgical Pioneering podcast series application available at the following link: https://surgicalpioneer.codedx.me.